there's got to be some questions because there's quite a lot of, potentially controversial things in that talk about what's possible. So does anybody have any questions for Rafat? I'm going to pick up Martin. I'm going to pick on you. Come on.
He's going to ask me about The Good Wife. we share interest in same shows on Netflix.
So what do you think, Martin? Because you know a little bit about the biology and the genetics. You know a little bit about the treatments. You know what's in the pipeline. Is this hype or is there some hope here?
No, I think it's really very exciting times. There's so many drugs in development, and it's going to have a massive impact. I mean, the one area where I'm not clear about how it's really going to come about are the ones that cause the most excitement in the solid cancers, the PD-1 and PD-L1 inhibitors. And I don't know what your view is. I know the data looks good, but then we know they can come in a subgroup of patients quite severe autoimmune side effects as well. And I think we are lucky that many of our drugs don't have that significant side effects. So how do you see the balance of that in a population that is often not really used to, of course, I'm not saying that our drugs don't have side effects at all, but I think it's a different thing if you're having an autoimmune colitis or if you have fatigue from an ongoing treatment.
Yeah, well, our patients are used to steroids, but that's not really the right answer. So the thing about it is that what you saw, I mean, the formula that I have at the end is really open-ended. I mean, I think the problem with lung cancer and other diseases that we sort of learned that if you get a cancer, you stay on drug the rest of your life. If you stay on drugs the rest of your life, you're going to see these side effects. So the question is that if you have to use drug like checkpoint inhibitor, not really sort of to treat aggressive disease, but to put more patient into minimal residual disease, and you use it for only 6 months, are you going to see the same rate of autoimmune disorder? Maybe not, but we need to start thinking really about an open-ended treatment. Treating until progression. I mean, the guy that I showed you, the first patients, had been without any treatment for 10 and a half years. If he's on some drugs, will he still be around? Will he have the same quality of life? How many times we would have to change treatment and the cost of the treatment? So I think getting it right and getting it right by maybe including minimal residual disease, whether it's just, the assays we do or add PET scan or some of the sensitive assay, I think that's should be the goal, to try to get it right early, open-ended, to try to reduce the side effect.
Okay. Yeah, Dr. Offer, I think it's you. Can't really see.
Thank you for the talk. The majority of our patients are elderly. There's a concept in immunology that in the elderly, there's so-called immunosenescence, and the elderly patients will respond to vaccinations with less effect. And one of the aspects that you were talking about is restoring immune surveillance. How do you think that we'll be able to restore immune surveillance to a level that will be clinically effective?
Well, that's a tough question. I'm not used to you in street clothes. I'm used to you wearing your bicycle outfit. You were impressive in those 4 days. But no, truthfully, I mean, the right answer is use less steroids, because I think we have really deplete the lymphocytes with all the dexamethasone we use. And then figure out ways to stimulate, the T cell repertoire and, the NK repertoire, the anti-KIR, approaches and things like that. But that, I think, is worth studying, isn't it? I mean, because I think the question is that why do we see more myeloma as we age? Is it because of the immune surveillance, and we need to do something about it. So I'm sure there are people working on that.
Okay, we've got time for one more question. We will come back to this topic in the panel discussion. So for all those of you that have questions but don't want to ask them now, we'll come back to that later. We've got time for one more question, and hopefully we've got one to make use of Rafat when he's on stage. Does anybody have any more questions? Yeah, I can't see who you are, but just over here. Thank you.
Thank you very much for the talk. I have a question about personalized medicine. I guess the notion of personalized medicine appeals to all doctors and patients. But the question is, lots of the myeloma studies and trials are actually dictated by the pharmaceutical companies and with very, I would say, little interest in trying to identify the patients based on their cytogenetics and treat them with the right medications. How do you see the gap or the funding can be perhaps secured to have more studies looking into improve the try to get the right medicines for the right patients at the right time?
Yeah. Well, we're all struggling with that, and even in a country where access to drugs can, be very easy. I think, so personalized medicine is very important, but I think we may need to come up with, we're still very primitive in our understanding of myeloma. I mean, we use FISH, and, FISH, I think, is sort of, T model when it comes to understanding the genetic of myeloma. So now we have, a next generation sequencing and trying to understand what make myeloma, really behave in a certain way. We may come up with better classification of myeloma. I think if we come up with better classification of myeloma, then we may have 4 different, arms to a study, makes it possible to, really do the trial quickly, understand if you're making an impact quickly. But if each patient, you're just going to look and, okay, I'm going to find 4 or 5 drugs and I'm going to use them, it's going to be hard to sort of, find the right way. So I think that's the problem with personalized medicine is, do we think that, are we at the time we can always say, okay, you have these certain, genetic aberrations, we can have 5 drugs for that, and this is what we're going to use. I don't think we're there. We don't understand that yet. But it could be by, sort of prospectively studying a lot of patients by these, new methods, and I think we need to get the right people who understand, because it's easy to sequence. I mean, it costs $2,000 and you get it in a week. But for me to look at it, I have no idea what's going on. So I need somebody who really understands this to help us design the right trial for a large number of patients. One day, maybe we will have the resources to just give the right drug to the right patients. But I think today is probably very hard. I don't know what your approach, Martin.